This is the Owens Recovery Science Podcast.
Welcome back to another Owens Recovery Science Podcast. Johnny Owens here with poor Kyle Kimbrell. His Astros got freaking walloped last night.
You should be really impressed that I'm here and I'm as chipper as I am, because inside I'm a big ball of emotional mush, broken hearted.
Well, sorry, man. You know,
it was bad too. We got destroyed last night. Like, it wasn't even a ball game. Most of those games have been pretty good. Last night, that was a butt whipping. Ugh.
Then they're just like hitting your players with pitches just to put salt in them.
Oh, hey, look, that whole business of our pitcher hitting their guy and their guy thinking it was intentional made no stinking sense. Even the announcers are like, this guy shouldn't be mad. Like, the situation, it makes no sense to hit that guy. So,
wow.
But then they hit us and we hit them, yesterday, and everything was fine. Nobody thought anything of it because they realized, I guess. Maybe they got it out of their system the other night.
Steven, I'm going to stop Kyle here. He's going to keep going on for another hour.
I can talk baseball a lot, Steven.
So. And I'm recovering, man. I spent 4 days at F1 Austin with the rich and the famous, mostly the rich.
That was a big bottle of champagne you were drinking.
Yeah, that was good, huh?
Yeah.
That was the end of the night. There's other pictures I didn't see you guys were working that much.
I don't know. You were fully clothed and looked like you were somewhat coherent, so it couldn't have been the end of the night, the photo that you sent.
It might have got a little worse after that. Let's just say that. Oh, dude, that was a blast, though, man. But a stupid sport. Like, you get done and we're waiting around. No, I mean, that part's cool. But like, two of the guys got eliminated for cheating, or not cheating, but something happened with their car. So the guy that went second, who I was rooting for, he basically, because something was a millimeter off, he was kicked off of the podium. So yeah,
racing is so.
Imagine if we did that in like football or something here.
No,
crazy though.
Yeah, if you're not cheating, you're not trying.
Exactly. Well, coming from an Astros fan.
Hey, I knew where you're going with that. Everybody saw the setup coming.
The Braves are out, so I can't say anything. But
that's right. That's why. Well, Zach's still in hiding, I think. He's still in hiding from that, because Zach sure did talk a lot about how good his Braves were all season long. He was
a puffy chested little dude.
Every week it was something about Acuna and run differentials, and I'm like, just wait till October, Zach. Just wait till October.
All of a sudden, he's all about the Eagles. You don't hear anything about the Braves.
Imagine that. Yeah. All of a sudden, he's quiet.
Just a wasted season, a historic season wasted, in my opinion.
Baseball, man, it's so brutal. So brutal. Yep.
Well, that voice you hear, that third voice, is a guest of ours that we're super excited about, because it's a little bit of a different podcast. So this is kind of a new venture we're running into, and so this is Stephen Ramsey. And if you listen to our podcast on VTE. With Dr. Hilligas was one of the leaders on that paper that the ABTA put out. She was talking about doing compression ultrasounds, and then we had quite a few people texting us, asking us about, how would you do these compression ultrasounds? Some of these folks are already kind of dabbling in the ultrasound world. And so Dr. Hilligas reached back out to us and said, I think it'd be really cool if people started to learn some of this imaging for safety, for objectivity, musculoskeletal imaging, or, maybe pulmonary imaging or things like that. And I have a rock star in the ultrasound imaging world that seems like would be a perfect fit for you guys to kind of work together. And so she linked us up with Stephen Ramsey, who knows this ultrasound imaging backwards and forwards. I think you have 5 CSM talks this year?
Yeah, it's too many. Yeah.
Too many. So he's in high demand. And what we are doing is we've partnered up with Stephen, and we're going to start doing ultrasound imaging courses, 2-day weekend courses where he kind of shares his knowledge and gets us all learned up on it. So he's going to be able to explain this a lot better than I can. But everyone we talk to about this course seems to be super excited about being able to take this on. And we think this is going to be the future. The more objective we can be with things that we do, the better, as well as the safety piece that we've talked about as well. So Stephen, welcome to ORS. Welcome to the podcast. What's up, brother?
Yeah.
It's an honor, guys. Thank you so much for having me. Even as a Braves fan, you guys have been really welcoming, which is nice.
You got Zach down there, so
Yeah.
we've already learned to kind of deal with the Brave side.
Yeah.
Give us your background a little bit. So I don't want to read your CV, but give me the highlights.
Yeah. So I've been a PT, graduated in 2014, and basically went straight into a residency program. I went into a residency in cardiovascular and pulmonary physical therapy primarily because I was working in the critical care setting and felt ill-equipped with what I gained from school. And so I've been working in the CVIQ setting. Been working in that setting for a while since I graduated, and primarily in a CVICU, working with patients on ECMO and other forms of mechanical support. Most of my research clinically is related to ICU, early mobility, and all these advanced devices that keep people alive when in many ways maybe they shouldn't be still alive. So I think that's an exciting part of our profession. But if I'm being honest, the reason I got into point of care ultrasound or ultrasound in general was because I was a bored physical therapist. I felt like I could contribute more to the medical team than I was contributing at the time. And I felt like diagnostic imaging was one of the ways that I could do that, especially considering the whole premise of point of care ultrasound is a real-time dynamic assessment of function, whether that's musculoskeletal or cardiac or vascular. And I felt like that's pairs really nicely with the profession that claims that we move people a lot. It'd be really cool to be able to objectively measure movement of different organs and function of different organs while they move. So that's how I got into it. And like many things, I felt like I sort of kind of struggled through the self-teaching of it. So I didn't really go to courses. I didn't really have a ton of direct education that way. I did a lot of on-the-job kind of training with physician assistants and MDs in the ICU. And all of them were, as you would imagine, basically just saying, why would you need to know this? And it was up to me to prove why I felt like it was valuable to our profession. So my background in ultrasound is cardiovascular and pulmonary primarily. So I do a lot of echo, a lot of aortic assessments, IVC, as well as DVT assessments, and then a lot of lung ultrasound, but have gotten my hands on a lot of the MSK world too. So shoulder, elbow, knee, hip, measurements of atrophy or hypertrophy, something that I've started to do quite a bit. And that has some direct application to the ICU, but certainly a ton of application in the outpatient world. So that's the brief CV. I have a longer version for the extended podcast.
Oh no, that was good, Stephen. That was great. Thank you.
We'll cut them off there. Yeah.
Did you get pushback at all from the MDs or PAs?
Yeah, so I started this in 2017, 2016, and I got pushback then, and I get pushback today. I mean, the reality is this is still something that's so new to our profession. The nice thing about ultrasound that's unique is that it's objective. It's hard to push back on somebody that's bringing an image or a video that you can put in the face of somebody that's skeptical, right? So I think that's the big benefit of this. And I still get the, why are you doing this, or what does it tell you? But with a quick conversation, I think it quickly turns into, okay, now how do we act on this information that you brought? So I think it certainly has enhanced my clinical practice and brought a ton of value to the patients that I see. But like you said, earlier on, I think that this is the next thing in the rehab profession in general, because I think it's just a way to make us a lot more objective, and a way to screen our patients that maybe don't have a primary musculoskeletal pathology, right? If there's a cardiac problem that mimics, something else, then this would be a great way to find it. So.
Yeah, we had a conversation early on with you. I mean, if even just talking about VTEs, and you're like, well, yeah, but what if you find it? Are you comfortable, that you diagnosed that or found it? But I would rather find it and be on the safe side than not know this is going on at all. Can you
Yeah.
expand on that a little bit?
Yeah, I think, what we have, if you think traditionally in PT, what we have is basically just symptomology. Do they have redness and edema? Do they, you throw out the Homan sign with some other archaic tests. But, the question is, if I do find something, what's the risk there? I think that there's no risk, because that just maybe informs my consultation to the medical team. There is risk with not looking for it and not finding something, right? There's not just risk from, your treatment causing harm, but that harm could lead to death ultimately, right? If there's a DVT. So I think that there's certainly a lot more benefit than risk to scanning patients, especially patients that have risk factors for VTE, which is 90% of our population. So,
Yeah. We, at our base, we had one of these big GE $40,000 systems. So there was a barrier to entry there, and now the world has completely changed, where there's these handhelds. You can even do them on your phone or your iPad. And so, a lot of people are like, well, I'm not going to buy one of these big systems, but they might not know these other things are out there. And then, as we've talked, even with some of the companies that make these systems, it's the education piece is a big missing component. And that, it sounds like, it's hard to learn this in a weekend course. You almost have to continue to kind of send in images and make sure you're doing well. But also AI technology might even make this even more feasible. You still need the education, but the machines might actually start to be smarter. Can you expand on that at all?
Yeah, I'll touch on the portable machines. I mean, almost every company has come out with a handheld machine. And so the barrier to entry into ultrasound is a lot lower from a financial standpoint. I mean, you can get a handheld ultrasound for $2,500 now, which, from on our PT budget sometimes is a lot, but the reality of the value that you get with that is, I mean, it's a no-brainer.
Yeah.
That's the first side. And I think you're exactly right. Like the actual AI technology that's coming out in certain machines and likely to be in all machines going forward, it's ensuring that even a relatively novice scanner should be able to find and obtain clear images and be able to get quality data. Because the truth about ultrasound is, if you're not scanning the right area and not scanning with good technique, it's a waste of time. So this AI technology and a lot of the guidance that some of this stuff will provide is huge for those of us that want to get into ultrasound. And I think that's only a couple of years away from being in almost every handheld, I imagine.
When you're working in the hospital in the acute care setting, are you typically using one of the big ultrasounds or walking with a smaller probe?
Yeah, both. I mean, I think that depends. I mean, there's still going to be limitations to the handheld. I mean, you're still going to have some difficulty getting some of the high kind of temporal resolution images. Some of the cardiac imaging is particularly hard with a handheld. So I'll still use the big machines in the ICU because it's right there. But if I'm looking at musculoskeletal, something that needs high frequency and really kind of shallow depth, the portables are pretty good. So looking at the lungs or looking at musculoskeletal tissue is pretty easy. Anything that I need deeper than that, I tend to get a bigger machine. But for most of us in the PT world, the handhelds are going to be all we need to get started.
On the acute care side, can you kind of take us through some of the assessments you might do in your day? Because that's a different world from what we typically do, but from pulmonary to aorta to cardiac and what you're looking for.
Yeah. That is, I think a lot of times I'm thinking I'm just kind of playing around, which is not true. I'm actually trying to get valuable data, but in a cardiac ICU, there's no shortage of images that you have access to that have been done in their admission. But I think what I tend to try to do is try to rule in or rule out a patient as far as how appropriate they are for therapy. For example, if a patient is hypotensive, I may ultrasound their IVC, their inferior vena cava, and see if it's a volume related hypotension. In other words, do they just need fluid? And if they do need fluid, well, then I better get them some fluid before I sit them up, because we all know what's going to happen if they're intravascularly dry and I sit them up. They're going to probably syncopize and everybody's gonna be mad at me about, so I think that's one of the rule in, rule outs. And then I also think, like I mentioned before, dynamic imaging is something that is completely new to this world. not just PT, but in medicine. So capturing contractility and stroke volume and function with movement as the sympathetic nervous system kicks in is I think something that is huge for our profession, being able to quantify and qualify some of that. Other than that, I'm looking for general like lung function or any sort of consolidations that may be present that maybe X-ray gave me some indications for, or gave me some tips that might be there. And I'm trying to just evaluate it a little further with an ultrasound. And the last thing I'll say on that is this is not new to physiotherapy when you're looking overseas across the pond. I mean, this is something that respiratory physiotherapists have been doing for years. And there's tons of articles that have even been published in the past couple of years about how to use ultrasound to measure diaphragm thickness or diaphragmatic excursion as a means to tell if a patient's ready to come off a ventilator. I mean, that stuff right there is huge. It's huge for our clinical practice to have that kind of input. And that's something that we could do here in the States that we haven't taken the reins of that yet, but it's something I think that's coming.
If we're looking then at something from a safety profile, like a compression ultrasound, can you talk about how hard that is to measure and what the steps are for that?
Yeah, that's one of the things that I think is going to be the first to hit the profession outside of just MSK, hit the outpatient world, is this compression ultrasound. I mean, you can within, 30 to 45 seconds, you're looking for basically compressibility of veins at a few specific areas. And what research shows is if there's compressibility of the veins around the groin and then compressibility of the veins in the popliteal space, then you can rule out with not 100% certainty, but some confidence that there's not going to be a DVT in the length of that vessel. And what we know to be true about DVTs, anything distal to that, there's a low likelihood that a calf or lower DVT is going to propagate up and cause any problems long term. So if we can rule out the two most common places, which is at the femoral nerve or femoral vein up there at the saphenous junction and then down in the popliteal fossa, then we should be pretty confident. I think the sensitivity, specificity are both over 90%. So it's a really easy test. And again, it takes 30 seconds.
Yeah. That ease, I mean, that's almost like a no-brainer there, because we do get lots of times, especially with the teams. I've got this guy and a history of DVT. Can we do something like BFR? Can we not? Should we be mobilizing? And have something like that at their ease is huge. Or if they currently were diagnosed with a DVT, where do we stand on that compression?
Yeah, I think that's a big question. I also think that there's obviously, if you give a diagnostic tool to, a bunch of new healthcare professionals to this world, and they start to find some things, there are going to be a lot of incidental findings that otherwise, that's the only, I think, hard part about this is what do we do with things that we find that we didn't expect to find?
Right.
And then
with
how
the
does
red herring.
Exactly. And then for us as PTs, it's not just about obtaining imaging, it's about the next step. It's the same thing for blood pressure measurements. It's not just about getting the blood pressure, which I recommend as a cardiovascular PT to take it.
What?
Blood pressure. Nice plug. I like it.
Exactly. And then
vitals are vital.
Vitals are vital. #. So it's not just that though. It's what do you do with that information? That's going to be the same question for diagnostic imaging. And even a bigger question is what do we actually do clinically with the information that we get? And, that's a big soapbox of mine that I won't use this platform for, but I just feel like the big question, I guess, as a profession is, are we ready for that autonomy, even though we've said that we want to be autonomous for years, right?
Yeah.
It's a big question.
Well, we all want direct access till we don't,
Exactly.
It's like, crap, I got to worry about this liability or this autonomy.
It sounds real good in school when you're going through, and then all of a sudden you get out and you're like, oh wait, this is on my back now.
Yeah, I'm my own boss, but can you help me with this because I don't know how to do it. So,
Hey, I got a question about the compression ultrasound to back up just a little bit. How do you do the compression? Are you just pushing with the probe, or?
Yep, exactly.
Are you just like mashing as hard as you can, kind of deal, or?
So you're just looking for does the vein collapse fully? So whatever pressure that requires. I mean, obviously, non-collapsible. It's not a lot of pressure, but a non-collapsible vein is going to be high likelihood for a thrombus in that area. And at times, you can even see the thrombus in the lumen of the vein. But it's really gentle pressure that collapses veins. And that speaks more to technique. Is there's a way, you start to scan these things and you realize that I can't even find a vein. And it's probably that you're pushing too hard already and you've already collapsed it. So that just goes with, back to Johnny's point, that this is still going to require quite a bit of education and hands-on sort of lab education to get the skills for this.
Yeah, well, we know from the BFR world, just with our tourniquets, we can give venous occlusion really low pressures. It doesn't take much at all. Right. And everyone's a little bit different with collaterals, but yeah, it's not a lot. So, I remember trying to do freaking like transverse abdominis and stuff back when that was like the hot and heavy thing in the military. And some of that stuff was a little bit tougher for me, but, quad was fairly straightforward. But can you talk about from the MSK side, like just trying to get different muscles in the shoulder versus ankle versus thigh and what the techniques and how hard it is?
Yeah, each joint has its intricacies. I remember when I was doing the elbow and learning the elbow, which seemed like, man, this is going to be so straightforward. I think there's some complexity there that requires some technique. And I think the hard part about MSK is the way that the probe interacts with some of the tissues, the way the ultrasound beams interact, is that there's this concept called anisotropy, which basically creates artifact where I can't, for tendons specifically, where I can't really see a tendon depending on the angle of my ultrasound. And I think that that's going to fool a lot of people when they get into this to thinking that there's full tendon ruptures and all that stuff. And it's just a really quick fix and a quick maneuver of the probe. But that's a general term. But as far as actually finding the tendons and watching the joints move in real time, it's pretty straightforward. I think for me, when I was studying the shoulder and the elbow, I think it probably took me 2 weeks to get a systematic approach down, right? And I think that's where we start, is what's the systematic approach to the shoulder? Where should I start? And once I felt like I had that down, it takes really, that's the hard part, is the months of scanning experience that you need. Because it's one thing to look at anatomy, it's another thing to actually find pathology and know what that means. So, but my encouragement to people, and that shouldn't be a discouragement, my encouragement is that let's start just looking at the anatomy, right? As a profession, we are anatomy experts. Let's evaluate the anatomy. And once we get really good about finding what normal anatomy looks like, it's going to be a heck of a lot easier to find out what abnormal anatomy looks like. So that's the encouragement. I would say that it's, you start with these kind of bite-size areas and then progress from there.
Yeah. And I think mentoring, like you said, part of this course will be ongoing mentorship and getting these scans and trying to make sure that people are proficient, because it would be amazing to have a full-on residency type certification because if we embrace this, we are anatomy experts, as you said, and there's just so much that we could probably use this for.
Yeah, I 100% agree. And I think that's the conversation going on in our profession now, is where does this fit in terms of education? Because it's not a question of if this is important. This is a question of where do we actually fit it? Does it fit into entry level? Which I think the answer is yes. Does it fit into residency training? Yes. Does it fit into post-professional courses? Absolutely. I think, you could start to see specific residencies pop up that are for, diagnostic imaging or ultrasound. I think that's certainly the case. I think it's so broad. You've got people in hemophilia using ultrasound, all the way to people looking at the pelvic floor, to crazy PTs like me doing cardiac assessments. And so it's such a broad topic that I think it probably fits best in each individual practice area initially until we get kind of our feet wet with it.
One of the things that we're very interested in the blood flow restriction side is atrophy to hypertrophy, and making sure that we're seeing our intervention is doing something. And, if BFR is going right, you should see changes, and sometimes changes kind of rather rapidly. So, if you were to say in this scenario, we have someone, post-op knee surgery, come in, they're pretty atrophied, and we're going to apply this intervention and we want to see over time, are we making an objective change? How would you go about getting those measurements? Serial measurements, how often? and the complexity of always making sure you're at the same landmarks?
Yeah, that's a good question. I think I would actually start with the pre-screening process, which would include compression ultrasound to rule in or rule out thrombus, right? I think that's the first question. And I think once that gate is hurdled, then I think we go to looking at some form of cross-sectional area or thickness measurement. So taking the thigh or the quad, I think you get there's standard approaches to this that have been well documented in the literature in the ICU for atrophy and certainly applicable to the outpatient, but finding a point that is the same distance from the ASIS and the superior pole of the patella, being able to measure cross-sectional area or thickness at that point and do that pre and post, right, for immediate hypertrophy. But then I think you also can do that serially on every intervention, whether you're using BFR or not, right? So sometimes you may not use BFR and you may want to just see, hey, are we still maintaining the gains that we had from the last session? And I think the thing that is starting to be studied a little bit is, and we've talked about the benefit of the compression therapy, not just on muscle hypertrophy, but on the benefits of shear stress and nitric oxide release and all the vascular benefits of BFR. And you guys and we've talked about some papers that have some bold claims related to vascular health and endothelial function, and it makes a lot of sense physiologically. So I think the other thing is, do we measure vessel diameter, arterial diameter, as well as blood flow velocity and see changes in that? And that's probably not as directly applicable to BFR, but I think it'd be interesting data to start to gather on these patients, just to see what happens pre.
It would for sure. I think, especially if I've envisioned a few different scenarios where that information could be kind of relevant. We think one, with the use of ischemic preconditioning by all these teams as a recovery modality, you wonder at what point do you start to get some vasodilation in that vascular system, like at what point does the tourniquet cause that result, which certainly is going to play a role in any sort of reperfusion that they get once that thing deflates. And you wonder if that changes over time, because this has been my question is, does the system adapt at some point to where, I mean, it adapts to everything else the human body does. It makes sense that it might to that. And so then you would need to know that really in order to give the same level of intervention that you gave, say, at an initial setting, or maybe you have to, there's a point at which we learn now we need to add some sort of exercise or something like that to kind of recreate this vasodilation, increases in shear stress, reperfusion results, all of that. So I think it's interesting very on that front, but then also you kind of look at it from the side of in the ICU, how quickly are these changes happening to the vascular systems, or what is the kind of minimal level intervention that we could potentially give them that physiologically is doing something that stuff could be immensely valuable.
Yeah, that's something in our ICU that we talked about a little bit, and we've obviously patients on ECMO with cannulas running down their thigh. It's hard to
What's
get
ECMO?
Right. It's extracorporeal membrane oxygenation. So basically just an external heart and lung machine.
Okay, got it.
So these are patients that, without this machine certainly are not alive, so it's stuff like that I'm like, hey, to our attending, hey, I'm going to put a cuff on their thigh and occlude blood flow. And they're like, wait a second, we just restored blood flow with this machine. Don't occlude it, So I think it's stuff like that I think is in certain populations, it may, that may be a challenge, but in most of our ICU populations, our general ICU, this is a no-brainer intervention that you're exactly right. I think gets us a lot of bang for our buck, because the reality is their endurance is so limited that a short session of mobilization with the addition of blood flow restriction may be exponential for them. It may be something that actually, provides a ton of value.
Something you couldn't achieve otherwise with that individual.
Exactly. No. And we see, I mean, these people, again, you hear the adage of how much muscle mass kind of that you lose per each day of bed rest. But I mean, these people, it takes months to years to rehab.
If ever.
If ever. And from a relatively short ICU, there's lasting effects. So I think starting this intervention early, but then again, to your point, getting some objective data is because our profession is moving towards outcome-based,
Yes.
intervention, right? And so if we're doing in the ICU is not actually helping, then let's not do it. Let's do something else, right? And I think that's where we don't really have great. The data has not caught up to clinical practice yet. So I think this is one way to do it, certainly.
I think that's a cool point on the just the ICU and talking about muscle mass, and because imagine this, like we get to a point where I get the report from the therapist that and it serially goes from like ICU to inpatient rehab to wherever to the outpatient, and we have these serial measurements of the vastus lateralis just showing and then we can kind of correlate that to these individuals' function, their quadriceps force output, and now we have really kind of objective data to say to these insurance companies like, look, dude, you got to pay more for this. It's going to take a time to restore this stuff. We have the data showing you that this is kind of where they started, this is what how much they've lost. We can kind of handicap that to a degree, how long it'll take to restore, but it also might help us kind of figure out if there's interventions that medications that maybe physicians could prescribe to kind of help nudge those things along.
Yeah,
well,
absolutely.
on the vascular side, we've always kind of said what BFR does to the vascular system seems like it might be this just massive win. And so if what some of the studies are showing, you get this arterial compliance improvement, and now we're it's like 4 weeks. You come in and you go to PT to do these interventions, and we're tracking and showing, okay, we've improved your arterial compliance. And all of a sudden, you've got these PVD patients who have, less ischemic conditions when they're walking or whatever. That's a whole new ball game to go after insurance payers. Now we're affecting the vascular system and we're objectively measuring it. I mean, that's huge.
Yeah. Not only from a cross-sectional area of the muscle, right? Because I think, if you don't have great oxygen supply to the muscles and the legs because you're ischemic, you're not going to build muscle. And I think that's one side. But the other side is you can actually literally calculate their velocity, the blood flow velocity, pre and post. Again, not in session to session and week to week, and actually see changes in their actual disease process, which is really cool.
And that could be really encouraging for
the
patients as well as practitioners. I think that's one of the hardest things about our profession, and I say it just about every weekend when I teach, but that's why I like exercise, because we kind of know that some of the targets that we need to hit, and we can kind of check that box at that point. Like, all right, they earned some muscle today because I know we did enough reps and sets and load, and then they're going to come in later in the week, and like we know we did enough, but I still want to know how long I got a range of motion and knee for before I increase their flexion or extension. Like, somebody please send me that paper where anybody's even tried to look at it, But we do it. We got to do it.
Well, like I said, though, for the patient and the practitioner, having solid objective measurements as a practitioner is so empowering. Because like you said, sometimes this profession sucks because you're just like,
it's
I think, I don't know, that hop looked like it was pretty good, side to side or whatever. This is like completely empowering. That's why I love this stuff. That's why, when I was in CFI, we had every toy in the world, and it made going to work awesome because it's like, cool, we're measuring everything. So I think
you can also look at, like we talked about diagnostic ultrasound for like the joint, and tendon health. You can actually see tendinopathy and actually see that improve over time too. Because I think I would imagine that BFR and shear stress does not just impact the vasculature, right? I think that there's all of this, the local microvasculature is getting benefited from nitric oxide release and vasodilation as well. So I think you actually, it makes sense physiologically, whether the data supports it, that the actual tendinopathies actually improve with this too. So.
Yeah, I forgot what it was. Even if you see that they're, that angiogenic response, the vascular bed in the tendon isn't great to have when you have a tendinopathy, but when it does improve, there is a linear correlation in symptomology as well. So you should see as that's clearing up.
Yeah.
And I think that's interesting. That paper that Kyle sent me about PTs being able to do ultrasound, or where's the future in this? It's diagnostic, it's interventional, and it is research. In the clinical setting, sometimes it's like, man, the research seems really cool, but I'd never be able to reproduce that Well, with this, you could. I
Yeah.
mean, so many of these BFR papers, it's measuring strength, it's measuring hypertrophy, or
Yeah.
you're measuring, arterial compliance.
Yeah.
Can you
I think
measure pennation angle with
yeah.
the? Okay.
Yeah. Absolutely. Yes. So all that stuff. I mean, I think the gap between the research world and the clinical world is smaller with ultrasound than it is with some other things.
Yeah.
I mean, the population maybe is slightly different, but I think that is one way where you can drop research straight into the clinical setting and start to use it.
Yeah. Yeah.
Yeah, there was I think that was one of the studies that Hardin Simmons did actually, where they used ultrasound to measure the swelling response. They were specifically looking at the swelling response, but they also were capturing how that swelling affected the pennation angle. Because as the muscle cells swelled, it would kind of alter
That,
its orientation. So
there's tons of things coming out on that. I mean, I think that's the one place though that the portable ultrasounds still struggle a little bit compared to the really really high frequency, high fidelity machines. So, but I mean, I think again, you look at the progress we've made in the handhelds. I think that there's some units that are 15 megahertz frequency and getting some really clear images. So I think it's a matter of time before the portables are equal to some of these
Yeah.
bigger machines.
They're just going to get better and better. Yeah.
Yeah, and it's getting smaller and smaller and better and better. It's a really fascinating growth.
And doing a dynamic muscular contraction image, that seems other than the TRA stuff that I did, is that hard?
No, I mean if you find the muscle belly and it's really easy to see the changes both in the short axis and long axis, you see the muscle contract. I think where I've primarily looked at this is at the myotendinous junction and the tendon insertion onto the bone, the enthesis on the bone, but certainly could get middle of the muscle and actually see changes in sort of the physiology there. So that's not a hard measurement at all.
Okay. And then what about bone?
Yeah, bone is tougher.
Yeah.
From just the ultrasound physics and how the ultrasound waves interact with bone, because it's such a highly reflective surface. What you can do with some degree of certainty is you can basically look at the surface of the bone, the articular surface, and see if there's actually fractures or floating bodies and things in the joint space. So that is there where you can start to see tendon pulling bone away from the cortical bone away. You can evaluate the depth of the bone and certainly can evaluate the actual the internal aspects of the bone really at all, because that surface is so reflective. But it's definitely good from a rule in, rule out. Is this an avulsed injury here? We can see that with some certainty.
Looking at actual joint, are there things that you've been able to look at diagnostically within the joint itself of, okay, I do see there could be a lesion on the articular cartilage or sort of meniscal pathology?
Yeah, that's where a lot of this stuff, I think there's PTs that are doing this every day. And it's a smaller network than I would think, but there's PTs across the country that are, diagnosing tendon pathologies, hemarthroses, they're diagnosing fractures, they're diagnosing, complete tendon ruptures on a daily basis. And so, yeah, certainly something that you can see again with some clarity. And there's physician groups in the sports medicine world that are going exclusively to their first line imaging being diagnostic imaging before they do anything else. Because the one thing, to your point earlier, the one thing that diagnostic ultrasound allows you to do is to get dynamic images of the joint. You can actually see the joint moving, and maybe a tendon pathology doesn't present itself until you actually get that full range of motion at that joint and start to see that distal thesis of that tendon. And then now all of a sudden, oh, there's the problem. That's where we're actually having issues. So it's unique in that way for sure.
Yeah. Yeah. I mean, for sports teams, I mean, this is a sideline intervention that is, out there with all of them. It's very easy to do and get a quick diagnosis. So definitely seeing it from a sideline perspective.
The other area that I was just thinking as y'all were talking, and we've talked a little bit, like, it seems like there's an obvious kind of military application here, but even like these municipalities that are like Denver, Colorado, where they're starting to hire physical therapists, athletic trainers, strength coaches. And one of the ways that they function is in a direct access kind of space. But, those groups are going to work pretty closely with their referring providers and whatnot. It's just, you're just like, you make the physician's job like that much better at some point because you've already gone in, saw the PT or whatever. They've got their report, goes back to them. I could just see it really kind of help in that
Yeah.
space a lot too.
Yeah, I think I see this as a double-edged sword, and so I'll talk about the positive, and also I'll talk about the negative potentially. You put this
Yeah.
in the hands of every PT. The positive is, I mean, you talk about how highly you're regarded among your referral source is if you're using this diagnostic modality and getting really good objective images and communicating with the physicians as a peer,
Yeah.
that's a huge deal. Now, the alternative is you're getting really bad images, making really bad assumptions, and then getting less
Yeah.
referrals. So I think there's a caution to this too, right? That's where, again, I don't want to continue to talk about this, but the training is so important, right?
Yeah.
Getting quality images, getting continued mentorship is such a huge piece of this, because I think the last thing we need as a profession that's getting into this space is to do a poor job with how we present it to the medical team and then them be some sort of backlash for that. So
Yeah, we're seeing it with BFR.
yeah,
That's why we harp on our, the course. And I think just really understanding how to do it right just seems to really help with everything. And then there are always
yeah,
just dummies that Darwin will take care of. They just can't get it no matter what. So
yeah. And that's
What
okay. I mean, this doesn't have to be the whole profession, right? This is the high
yeah, I know.
achiever people
Tip of
that
the
are really
spear.
interested in the
Yeah.
data. So,
I know, Steven, so I was looking at some of the requirements, like for the physicians for ultrasound to be, what is it, the registered MSK or
yeah,
something like that. And there's a whole like a test you take and that sort of thing. And it looks like the Ortho Academy is working pretty closely with APTA as well as that physician accrediting body
yeah,
to roll this out to PTs to where basically, PT could at some point take this test
Right.
and be, credentialed
yeah.
in
That
this. What does what does that education process kind of look like, and how does what like we're going to be doing fit into that and that sort of thing?
Yeah, that's a great question. So it gives me a chance to talk about, all the work that's been done on the front end of this. There's people that are truly pioneers of this that have created a relationship with these traditionally physician-based organizations that
Yeah.
recognize physical therapists as diagnostic practitioners, that recognize physical therapists as the experts in anatomy, and have made a, through the APTA and RDMS and all these groups kind of working together, they've made a way for PTs to have a pathway to sit for their RMSK, not just the sonography version, but through the APCA, which is the physician credentialing side of that. So,
Right.
and not only sit for it, right? There's people across the country that have sat for it and nailed it and have passed these tests and demonstrated that they are on par with, anybody out there from a diagnostic ultrasound standpoint. The hard thing about, the credentialing thing is going to be a big question. And where we go from that standpoint as a profession is going to be a big question mark. I think, requiring it to be a credentialed type of skill probably doesn't make a lot of sense, but it's nice to know that there's options for sort of quasi specialization in these various areas. Whether you want to get the RDCS, which is specific to cardiac sonography, or the RMSK, that's musculoskeletal. So, but the RMSK is the first one that really PTs are sitting for and passing and actually making a huge splash from that side of things.
Very cool. So I think we need to go over kind of what your course is like. I was just looking at, just talking about the advancements of where we're going to see things. There's that muscle sound unit that I sent you, which is using ultrasound to measure malnutrition and measure cachexia and sarcopenia in individuals, which is going to be nuts of things that we might be able to do in some of these populations. And when I was speaking at Southwest Research Institute, I mean, they have an ultrasound that's about to come out that looks at muscle at the fiber level, and then they are moving next to cellular level. So it's going to be freaking nuts what we do with this stuff, man.
Right. Yeah, it's crazy. I mean, that you talk about the application in the ICU right there, it's huge, right?
Yeah.
Because one thing that we know to be true is nutrition is so valuable in these patients that can't eat by mouth for weeks and weeks. I mean, how are we actually supporting them, and are we supporting them enough, right?
Yeah.
That's the question, because they're not going to build muscle if we're not supporting them. So
yeah, now you're going to be able to measure it.
Yeah.
Very cool.
Yeah.
All right, man. So let's go over your course, how it's going to roll. It's a 2-day, Saturday and Sunday.
Yeah. Yeah. So I'm excited about it. I think this is truly a general diagnostic ultrasound course. It's, the first whole day is MSK. So we'll do some shoulder and elbow, knee. We'll do some cross-sectional area measurements and thickness measurements. We'll throw in some Achilles tendon as well. That'll be all day one. Now, probably a third of that day is truly just didactic, getting familiar with what it looks like on an ultrasound, and then the whole second part or majority of the day is going to be getting an ultrasound probe in your hand and scanning and getting comfortable with each of the joints and the various techniques for scanning. And then a big part of that has to be, what's the clinical application? How do we actually leave that day and start to apply it the next day? Is going to be a huge kind of point of conversation, which obviously is unique to each area that you're practicing in. So whoever is attending, it's dependent on where you're practicing. The second day is really, I say, kind of my love, which is the heart, the lungs, the aorta, and then DVT. So spending some time there, which I think, on the surface, I think that I've talked to PTs about this. On the surface, the question is, well, why do I, what would be the benefit of that? Or I've had people say, I want to come to the MSK part, but not the second part. And I think many of the things we've already talked about is the benefit of that second day is the differential diagnosis part in your clinic,
Mm-hmm.
or the actual quantitative data when you're exercising somebody to actually see cardiac function change or rule in or rule out pneumonia or lung pathology. I think those things are valuable and something that if I told PTs they could do it, they'd be excited. I think it's just us learning that we can actually do stuff like that.
Yeah, explaining that. Yeah.
And then I think to your point, I think going after the course, there's got to be some form of resource sharing or mentorship that occurs, which is a platform that I'd like to host, through my own personal company. Is just, hey, if you're new to ultrasound, why don't you set up a meeting with experts and send the images, talk over the images. There's even through GE, and I think other probes have this, the portable scans. You can actually, through the app on your phone, scan in real time and video call with anybody else that has the app. I mean, that's nuts.
Yeah.
Be able to, hey, I'm going to set up an hour meeting when I have a patient that I know I want to ultrasound, but I want to call in the expert when I'm doing it and get some feedback in real time. That's
super interesting.
That stuff is so cool. So that's going to be the big piece that I think we're all figuring out. What does that look like after you get the initial training? What does it look like to maintain some competency there? Because it can, you can lose the skill pretty quickly as quick as you gain it. So that's a big question.
Here. Well, and poor Steven, you're going to have to train all of us.
Yeah.
Here at ORS, because we're all dying to take this course. Your first course is in Atlanta.
Right.
Your hometown. And so what's the date again? Shoot, I should have looked it up ahead of time.
The 11th and 12th of November.
11th and 12th of November in Atlanta. And so if you go to our website, we have a link that'll take you directly to how to register for this course. I'll also throw out there, he is charging way too little for this course. So get in while the getting's good.
Get in while you can.
this price point. Where are we at now? Are we even?
I think we settled at 800. Is that right?
I think it's 800 for 2 days.
800 2 days.
Yeah.
All right, man. Well, yeah, get in while the getting's good. And so we're just now got this going. We're already getting some registrations. I heard come in. And so everyone, it's not at a huge clinic. It's at Zach's clinic. So space will be limited, and Steven's limited in how many people he can teach on this, but it's going to be
enrollment, generally speaking, is going to, which is part of the reason we also are like, it's cheap, because you're going to get a small class. It's a lot of time with the instructor, so
with a real expert in this space.
Yeah, I think the benefit to this type of course, and I've kind of audited some courses like this on the medical side. I mean, you talk about learner to expert ratio has got to be low for ultrasound. You can't be, one educator for 15 therapists. It's, our goal is 4 therapists, maybe 5 therapists per educator. So that's the benefit. It's not, you're not coming to watch other people ultrasound, you're coming to ultrasound yourself. And that's a huge, learning piece to this.
Yeah. It's amazing. That's why we love what you're doing, man. And then in case people are looking for other dates, those will be rolling out. We've got to get through the early part of next year and the holidays. And Steven's like 20,000 talks at CSM and working booths and things like that. He will be at our ORS booth that we have there. So we'll be able to demonstrate, some of this technique, but check our website for more dates there. And Steven, it's awesome, man. Love working with you, brother. Can't wait to become an ultrasound specialist. I'm old. I got to check for DVTs every morning.
That's right. Yeah. It'd probably be safe. Yeah. Yeah, the lifestyle too, man. You're traveling all over the place, man. You gotta make sure you get off the plane and start assessing for DVTs.
Well, I think bourbon is supposed to make your blood thinner, so that's typically.
I mean, the research is inconclusive, but I subscribe to that as well. So,
well, we just need more data. So
more data.
That's my motivation.
Yeah, that's right.
Well,
I'm looking forward to it. Yeah,
appreciate it, man. Everyone, check out our site, look at the course content, and hit us up if you have any specific questions, because this is going to be really badass. All right, man.
Recoveryscience.com.
Oh, recoveryscience.com. Yeah, I'm supposed to say that. Yeah. All right, peace out. Hook 'em horns. Let's go.
Yeah.
Okay.
All right. See you guys.
See ya.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through. But also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.